Hello, everyone, and welcome to our weekly webinar session. Today we have Will, who will be presenting about Parkinson's disease. I am going to let Will start off his presentation now.
Hi guys, thanks for all attending. Thanks for coming to listen. Hope you're all well. My name's Will. I'm one of the Foundation Year 2 doctors currently working at Leeds General Infirmary, currently on the stroke wards. I was just going to do a short presentation on Parkinson's disease. So what we're going to cover is just going to you should be able to recognize Parkinson's disease from the cause of Parkinsonism and outline its pharmacological management. Able to recognize the symptoms of Parkinson's, name some investigations that you need to do, be aware of that, and then be aware about how to manage it. And then at the end, we'll just look at how to manage common scenarios that you may encounter when on a ward or maybe on call with patients with Parkinson's disease. So there's two things that can get quite confusing. Is there's idiopathic Parkinson's disease versus essentially called Parkinsonism. Parkinsonism is essentially the symptoms that everyone's familiar with Parkinson's, so which we'll go on to in a moment. But classic things like tremor, rigidity, but that can have many causes, and not all of them are related to Parkinson's disease. Idiopathic Parkinson's disease is essentially its own condition or syndrome, which is a progressive neurological syndrome, and essentially what they both are caused by is a reduction in dopamine, and the dopaminergic neurons in your substantia nigra, which are in your midbrain, essentially stop producing dopamine, and sadly the cause for that when it's idiopathic is in the name, so it's unknown, but there's a few risk factors linked to it, and then Parkinsonism can have other causes that we can go into, things like stroke, etc. So for idiopathic Parkinson's disease itself, there is no real cure. What we can do is essentially try and treat the symptoms, so there isn't any sort of long-lasting effects, but essentially it is inevitable that you won't be able to cure the disease. So as I said before, here are some of the symptoms. So quite a common ones that we all know is something like bradykinesia. So they might be very slow in their movements. And you can do this by doing a finger-thumb test where you get the patient to repetitively put their index finger and their thumb together, and it will be quite a slow action, whereas someone who hasn't got the disease or younger can do it quite quickly. You'll see with these patients, they become maybe initially quite fast or normal, and then it slowly becomes quite difficult for them to do, becomes very slow. Rigidity, so it's heard something we call lead pipe. So when you do a neurological exam, you're testing motor, you see how to test the tones, you try and make their arms go floppy, for example. And then with someone with Parkinson's disease, they're very rigid, like a lead pipe. So almost like their arm has become this very stiff arm or stiff pipe. And then again, you can get this thing called a superimposed tremor, where, for example, when you're sort of testing the tone in their wrists, rather than it being quite smooth and relaxed in a fit and well patient, these patients can get something called cogwheeling. So they sort of have these jerky movements where you feel like there's something like a wheel turning between the different cogs. Another common one is tremor. So this is importantly when they're resting, and so they're not doing any action. And interestingly, with Parkinson's disease, when they're doing an action, their tremor seems to go away. The common one you'll notice with Parkinson's disease is a pill rolling, where they'll put their thumb and sort of be rubbing their thumb around their index finger, and that just it's sort of in the background, and it's quite a slow, high amplitude but low frequency tremor. And another common one is postural instability. So a lot of Parkinson's disease patients, they have trouble sort of standing up, and from getting from a sitting to standing position, maybe have difficulties walking, so they sort of have a shuffling gait, where they'll take very minimal steps and just sort of very small steps, and the feet don't really leave the floor. And then a common test you can do for this is shoulder tug test. So you get a patient to stand up, and then you get obviously stand behind them and make sure they don't fall, and maybe get someone as well to stand in front of them in case they go the opposite way. And then you sharply pull their shoulders back. And then in a patient with Parkinson's disease, they'd struggle to sort of correct their balance. So it's a sign that there's some postural instability going on. On this, you can see on the side as well, there's a few other ones that are similar. So there's like when you see the shuffling gait, there's quite a characteristic gait they have, where they have very static arms and they'll have very reduced swing. It'll be a very slow walk, and it appears to be very rigid as they do it. So more additional ones as well that you can do as further tests is micrographia. So patients with Parkinson's disease can have very small writing, and so it's quite a simple test to do on the bedside if you want to sort of elicit this sign, when they can either draw their name or draw a spiral, and they'll be very, very small in their writing. A characteristic thing is hypermimia. So it's an expressionless face, so it's almost as like looking into the distance, or they're in deep thought, and there won't be much going on in the face. It'll be very blank, expressionless, as it suggests. These are all quite common signs and symptoms for Parkinson's. And then we've mentioned about the gait as well. And again, with the characteristic side of it is may have their head forward as well as an open mouth. Eyelids might be fairly sort of don't look normal, like a drooping or a dropping. And then quite common as well, they haven't got much control of their motor sort of swallowing. And there's obviously quite a lot of risk, and you have to be concerned about swallowing with Parkinson's disease patients. So there is some drooling going on potentially. And then other things as well that can sometimes be maybe the first things it might pick up on, or it might be the things that a lot of the time you might be dealing with on a ward or in the community, the other sort of other things that you get with Parkinson's, or the problems. So an example of a non-motor symptom would be something like depression. And it's hard to maybe tell if the depression is caused by being diagnosed with Parkinson's disease and not having the ability of being quite slightly older, or that they can go hand in hand. Also, you can get the side effects of it being that you can become depressed. Constipation is another common one in Parkinson's disease with non-motor symptoms. You can get a lot of change in taste and smell. So, for example, they might then start to only like things like quite sour, or things like sharp oranges, lemons, things like that. You might start to notice they're eating those sort of things because they can taste those things. Another common one is urinary incontinence. So you get a lot of patients on wards who are struggling with urinary incontinence, or might have catheters inserted because of problems like that. So that's another thing we might have to deal with on a ward. And another common one as well is sleep disturbance. So a lot of Parkinson's disease patients have insomnia, so they might have odd sleeping patterns, might sleep a bit more in the day, and then be wide awake at night, and they can't get to sleep. So it's not an interesting one on a night shift. You're covering an on-call a night, that you might have a lot of agitated or Parkinson's patients awake at that time. So importantly for us is how to investigate Parkinson's disease. So ideally, you can do a lot of it on a clinical assessment, which is essentially taking a history and doing examinations. So your neurological examination is really important. It's where you can test things like gait. You can, things like simple tests like the micrographia, get them to try and write their name. If they've got any other side effects, like they've got the constipation, or they're in any pain. A lot of patients with Parkinson's have unexplained pain we can't really find a cause for. And then you can obviously then do things like your upper and lower limbs sort of neurology. So if they've got any increased tone, rigidity, and what sort of their like baseline for things like their power, sensory, etc. And then The other thing you want to do with a clinical assessment is things like bloods. So this can exclude other causes. So if patients are coming in with maybe depression, constipation, increased rigidity, bit of confusion, you want to rule out things like strokes or infections, anything like complications of diabetes or cancer markers. So it's quite important that you can get blood tests done just to make sure you're covering all bases. And brain imaging's another major important thing for Parkinson's, that is not necessarily done maybe straight away, but is done later on to try and pin down a diagnosis. So, for example, CT heads, that might just want to rule out if you think like an ischemic stroke that's causing some of the symptoms, because they can have similar symptoms initially. DAT scans, this is quite important when you have, there's different types of Parkinson's and then different causes of Parkinson's. So that can help rule out which type it is, or pinpoint, maybe help your management slightly better. And then quite an important one, or quite an interesting one, is if you're unsure and maybe thinking that it was Parkinson's disease, another way to sort of work it out is to just start them on some sort of dopamine treatment. And if their symptoms improve or they seem to get better on the dopamine, it gives you a bit more certainty or confidence that it's maybe more Parkinson's that's causing these symptoms. So that's one that you can do as well. So it's quite scary list, but it's not quite simple in the grand scheme of things on how to manage Parkinson's disease. Very, very rarely as a junior or as a medical student, you're not going to be starting patients on medications or considering medications for them. But I think it is quite important to understand the names and maybe just slightly how they work, so that when maybe if you're clerking a patient or if you're reviewing someone's medications, you can understand or recognize what these medications are and understand they're important. So quite a common one is the standard of levodopa, which is essentially giving the patient dopamine, which is what they're lacking, and combining that with something that can prevent the dopamine being broken down. So quite a common one is co-carl-dopa, which is those two combined, and Madapar is another one that a lot of patients have as first line. The good thing about this is as well that it can be effective for a long time. So you can start a patient on something like Madapar, and by maybe increasing the dosage every so often in intervals, this can have quite good symptom control. So you can have someone who's comes in who's really struggling with sort of doing their daily activities, cooking and things like this, and you can give them the Madapar and they can be quite comfortable then for a long time after that. So yeah, that's the main one that's usually used first line. But as you see, you can have some quite common side effects that maybe you need to be aware of if these are being listed on the ward or something like that. Hallucinations, postural hypertension. So you don't want patients to be dropping their blood pressure too much, just being wary of that. So you don't have any complications like a fall. You can also give them a COMT inhibitor, and this is usually used second line when they're starting to lose the effects of the levodopa. And this essentially stops when you're sort of having the breach, when the dose concentration's coming down, maybe near the end of the day. It can help prevent that dopamine being broken down even further. So it helps just keep up symptom control and symptom management. But sadly, as with all medications, you kind of still get these side effects, which we can hopefully try and treat as well and just manage. But a common ones are nausea and diarrhea. And then, so once you sort of exhausted those or tried those, or they might not be suitable, we can move on to things like MAOBs or dopamine receptor agonists. So MAOBs reduce levodopa peripherally, and they used to be first line, but aren't used as much. I think levodopa is sort of taken over and has a lot of interactions with other medications or foods. So I think it's one that's less used, but still can be used in Parkinson's. And then other things, if people are starting to get problems maybe with swallowing, dopamine receptor agonist is quite good because you can get this in a patch, and it's just another management way we can try and help with symptoms. So there's some examples there: ropinirole and ritigatine. And again, as you noticed with me, a lot of them, the common side effects are hallucinations, postural hypertension, nausea and vomiting. So as a key rule, you can sort of keep those in mind for when you have a Parkinson's patient. If they are presenting with these things, they could potentially be as part of their Parkinson's medications. So that was just a quick overview. I thought I'd just go through a few situations or clinical scenarios that you might encounter on a ward or in an exam or something, to just appreciate our role as clinicians in treating people with Parkinson's disease. So here's a 70-year-old patient who has idiopathic Parkinson's disease. It's usually well controlled, but he's currently nil by mouth because he's due to have a surgery. And you've got a problem that, as we all know, Parkinson's disease medications, they need to be given on time, on the exact time every day. Because if you start to miss the timings, there are periods where the patient isn't going to have dopamine, essentially, and they're going to get a lot of problems with that, especially if they've been on it a long time and their dopamine levels have really, their own natural dopamine levels have dropped. So if you're then restricting that, they're going to get a lot more problems. So essentially what the question is, what would, if you get asked by a nurse, what would you do? So there's a few ways. So, well, the main way, so obviously with nil by mouth, the problem is they can't swallow their medications. So one thing to do is you call maybe the pharmacy team or the on-call pharmacist and just gain some advice about trying to get a good history off the patient of what medication they're currently on in terms of Parkinson's medications, find out what the doses are. And then there's quite a good website that I've used called Optimal Calculator. And the answer can be that you essentially convert their medications to a patch, so that they don't have to then take anything orally. They can basically have something put on their skin, and that can give them the dopamine. So you can have ritigatine patches, which can give them the same dose of dopamine as then as on the medication they're currently on. And so you basically put in what they're on, what medications they're currently taking orally, what dosages, and then the website converts the dosage into what would need to be needed for a patch. And then you can order this from the pharmacy, or the nurse can order from the pharmacy and get it sent down. Alternatively, if they're known they're going to be nil by mouth for a long time and they might not be able to, if they've got an at-risk swallow, or they're really struggling to swallow or take tablets, you can consider an NG tube, and then medications can be given through the NG tube. So next one. So you called about a 75-year-old patient who has Parkinson's disease and she's very agitated. What do you need to do? So essentially with an agitated patient, there could be lots of causes for agitation, not necessarily from Parkinson's disease. So what you always want to do with this is go and review the patient, do a full A to E assessment, and you want to look for anything that essentially might be causing just stress or pain. So you could ask or find out of any infective symptoms, sort of that's causing them to make some abdominal pain, like if they've got a urine infection, they might get some suprapubic pain. Any other causes of confusion, like are they showing any signs that I've had a fall, any C-spine tenderness, any bruising on the scalp, to indicate that they've now become confused, maybe from a intracranial hemorrhage or bleed. And then, even just having a good inspection of an A to E, so they might start to be developing pressure ulcers that might be causing a bit of discomfort when they're on the bed. So you want to make sure that you can control all the things that we can control that cause agitation. And a lot of the time, it might just be that you need to orientate the person to where they are. So sometimes if they're in a room on their own and they haven't got, they're not confused about where they are, like if there's no window or if the curtains are closed or they're feeling quite warm, things like this, you can just try and resolve those environmental factors quite easily. And a lot of the time you can get maybe a nurse to one-to-one them, or a HCA who can just sort of keep an eye on them. Maybe, if they're asking out for things, you can get them, water, things like this, fluids, just to help them out, and then just keep an eye on them in case they're not causing a harm to themselves. And then, if they are becoming really maybe aggressive, or they're a danger to themselves and they're trying to throw themselves out of the bed, or, attacking other members of staff, you can, at the end of the day, sort of give them medication to try and calm them down. Although importantly, not to give them antipsychotic medications like haloperidol, as this has a disastrous effect in terms of interacting with medications and Parkinson's disease as a whole. So the agitation medication you probably want to give is lorazepam, and start off with a very low dose, like 0.5 milligrams, and you can give this IM or a subcut if needed, or IV, or orally if they're willing to take orally and they've got a safe swallow. So there's the lorazepam is the one that seems to do quite well, and on elderly patients it may be a bit more frail. Starting off with a lower dose and working up is always the best thing to do. And then next one. So you have a 65-year-old patient who has Parkinson's disease, which is usually very well controlled, but now she's getting side effects potentially of nausea. So wanting to prescribe something, you've been asked to basically give her something to help with her nausea. Again, you want to just make sure that you're ruling out any other causes of nausea. So you want to do an A to E, look for any distended abdomen, if maybe they're constipated or bloated, and manage that appropriately, or look out for things that can cause that. Again, some simple things like just infection. You want to check their observations if they've got any fever. Maybe do a set of bloods just to find out a cause. Maybe it could be gastritis, or even something more. So like maybe like causing like a biliary colic or something, like into the liver. So you may want to just rule out those things out with a set of abdomen bloods. Review their medications again, just to see if there's anything else that could be interacting or causing the nausea. And then if you do think that they could do with some antiemetic, or you can't do anything, but you think that this is probably likely to do with the side effects, or you think that they are needed some antiemetics, the safest ones to give are cyclizine and ondansetron, especially in Parkinson's disease patients. And you want to avoid metoclopramide and chlorperazine, as these are antidopaminergic. So they're working against dopamine. So you're going to essentially cause worsening of the Parkinson's symptoms. So the main ones to give are ondansetron and cyclizine, which are a bit more safer. Furthermore, if they are vomiting, you need to worry about things like aspiration, and if they are at risk of swallowing, at risk to swallow, sorry. And therefore, you need to start thinking again, like if they're going to be vomiting a lot, if they're going to be potentially aspirating, to start thinking about converting to a patch. So it's probably good to get ahead of that rather than dealing with it when the time comes close to when the medications are needed. So if you are thinking about that, to get a patch maybe in the pipeline, because sometimes it can take a long time to get delivered down to the wards. And then lastly is this patient. So he's an 85-year-old patient with Parkinson's disease, normally well controlled, but now he is very, very constipated. What do we need to do? Will this affect his Parkinson's disease? So again, quite repetitive, but you need to be looking at anything that be causing the constipation, asking about their normal bowel habits. It might be that they haven't opened their bowels for 3 days, and then someone's saying that, oh, now they're constipated. But if that's normal for the patient, or they only go once in every 3 days, which is in the limits of normal, then that might just be normal for the patient, and then doing any further interventions is going to be worse or harmful to the patient than not doing anything at all. Asking about their diet, like what they've been eating, is there anything that could have been obviously caused if it's just basically having a poor diet, or they haven't eaten much in the last 3 days because they've been unwell. It might be explaining why they haven't opened their bowels that much. They need to rule out things like bowel obstruction or any more sinister causes. So asking about their bowel habits, have they had noticed any bleeding, PR bleeding from the back passage, or any vomiting? Have they noticed any bright red vomit, or maybe even coffee ground vomit, to make sure those are things are ruled out. Again, check medication, because a lot of these things are caused by medication, and it might just be a simple fix, maybe either switch it or get over this hurdle and then start thinking about changing the medications. And then, so if you are thinking, and then if for constipation itself, if you do think that this merits some sort of intervention, you can just give things like laxatives. So Laxido is quite a strong oral laxative that we can give as a liquid, and that usually gets a lot of people's bowels moving, or Movicol. And you can also give things like glycerol suppositories, which is another way you can, if the oral medications aren't working. And then lastly, if you're really struggling, you can give patients enemas. And then you can also give quite a few enemas over the course of the day. So if it's the first one's not helping, you can try again. But importantly, obviously, if you're thinking if someone's quite constipated, you've got to worry about maybe if there's some problems with absorption of the medications, as well as if you're over treating constipation and someone's bowels become very loose, you might be losing that concentration of dopamine from the oral medications. So it's just to be aware of monitoring that. So if they maybe develop loose stools, maybe thinking of the opposite. So maybe looking out for worsening of symptoms of Parkinson's disease symptoms. Or if they are constipated, they might be getting more absorption potentially from those medications. So you don't want to be then over medicating a patient, because then you'll obviously get more of the side effects of the Parkinson's disease stuff. So that was just a brief overview. I hope you enjoyed it. I'm open to any questions. Thanks very much.
Hi, so I think we do have some questions from the group. If I start from the bottom, Haley Louise asks, how early can Parkinson's start in the brain when it's in the family, and in the family, parent and grandparent?
I'm not, in terms of, there is a genetic component, and I understand that men are slightly more likely to get Parkinson's disease than women. The average onset for Parkinson's disease is maybe around 65, and then you can also get it when you're a lot older. Importantly, if you do get a bit older, it's quite a good prognosis, really, because if your medications, if the treatment can be successful for 10 to 15 years, that puts you into a lot of a older age, that hitting your 90s. So it's less of a concern. With early onset, it can vary very much, and there are anomalies or cases where you have been extremely young, but I think around early onset is around 40, I believe. If obviously all the environmental factors, genetics, all coming up, combined together, it's been known that early onset variety can be around 40.
Thank you so much for that. I think there was another question about whether olanzapine was safe for Parkinson patients, but it looks like Gabby has kindly put a BMG link as well up there.
I don't think it's not that well tolerated, I don't think, as far as I can recall. In terms of, I'm guessing it's because of things like to control maybe psychotic symptoms and things like this, that you'd use it. I think clozapine, and believe is, and I was my job on psych, I had a few Parkinson patients. I think clozapine is a bit more effective, I think, but it has a few more bad side effects or things that are unwanted that we have to take a risk with. And then importantly, if you are considering medication, it's always important to, like someone's put on the link, so BNF is always a good place to start if you are concerned about. I know I was very concerned when you're starting any medication for a patient who's got quite a important disease like Parkinson's disease that does have potentially a lot of interactions, things like even like antibiotics. I'd always just check the BNF to make sure there's no contraindication there that could cause worsening of their symptoms.
That's very helpful. I think Vinci Vinod asked, could you tell a bit about obsessive compulsive behavior secondary to dopamine agonists and how to manage them?
Yeah, so people who I think are known, I think there's a lot of cases where they become quite risk takers and patients become they sort of might gamble lots of money, or might just go out and buy loads of things. And it's something that you have to be careful of with a patient like that. I think it is a side effect and it is a concern. I think importantly on that side of things, it's just making sure they've got a good social network around them that can just make sure they're not doing those sort of behaviors. If you are worried, you can do things like you can have lasting powers of attorney, or maybe take over financial responsibility for their relative. I'm not. Forgive me. I don't know if there's particularly anything you can do. So apart from if it is starting to be a problem, you can obviously try and stop that medication that's causing the compulsions, and maybe try a different one just to see how they tolerate it. But yeah, on the whole, I think it is just keeping an eye on it, and just it's not. I don't think it's extremely common, but I do believe it is there. So I would, yeah, it's just mainly just safety netting, keeping an eye on them, keeping an eye on those behaviors, really.
Okay, thank you. That's really, really helpful. I think Ibnu Adam has a question. Can ondansetron be given for vomiting in Parkinsonism patients?
Yeah, so ondansetron is quite a safe one, really, to give. The ones that you don't want to give are like metoclopramide and prochlorperazine. So ondansetron, in terms of in general for all patients, really, it is quite a handy one to give. So I know a lot of chemotherapy patients have ondansetron as well, because it's generally quite well tolerated, doesn't have as worse side effects as the other antiemetics, and can be given in different forms. So it can be given IV, orally. So ondansetron is safe in Parkinson's disease.
We've got a few more questions if you don't mind, Will.
Yeah.
Sanai Meman asked, could you please elaborate on drug-induced Parkinsonism?
So I'm assuming, is this for things like, there are a few, let me just try and think. So I know a lot of, you can get extrapyramidal side effects with a lot of antidepressant medications. So things like some of the antidepressants and antipsychotics, can cause sort of things like lip smacking, increased tone. So it's mainly, as far as I'm aware, the ones that are to do with sort of mental health patients that can cause it. And so essentially with those, you just basically need to review their symptoms every so often. I think the only real answer for it is to stop the offending medication and sort of maybe find an alternative, and then once they've stopped that, to treat the symptoms as and how they present, and then hopefully that should settle down when you've changed the medications. So yeah, that's how I was aware of the drug-induced ones.
That's very true. Ibnu Adam has a question. He asked, any neurosurgical innovation under research for Parkinsonism?
Ooh,
That's a tough one.
Yeah, that's a tough one. I know there's been a bit more move away, I think, to in terms of innovation, they can sort of have or maybe a constant feed of dopamine, if that makes sense, like a pump, rather than taking these medications that obviously has like an end dose concentration at the end. So they initially, they've got a peak concentration dose, and then after that they tend to reduce in effectiveness because obviously the concentration is going down. So I think there is a lot that is trying to look in towards maybe giving a constant dopamine, a bit like insulin pumps. And also I think as well, things that can help with symptoms. So if someone's having very severe tremors, you could get things like nerve stimulators that can try and calm those symptoms down rather than just solely relying on dopamine as the sole treatment for it. You can so there are innovations. I wouldn't say I was an expert to give you the full breadth of those, and I'm sure there are people that are trying to really change the way it's managed, but those are the two that I was aware of myself, I think.
Thank you. I think we've got one more question. Aksa Mariam asks, I've read that domperidone is the gold standard in Parkinson's disease because it is least likely to cross the blood-brain barrier. Is this not true in practice?
Is the gold standard, sorry?
Yeah, I think it sounds like Aksa's probably read in books that domperidone is the gold standard in Parkinson's patients because they don't cross the blood-brain barrier. And whether we actually do this in our daily practice.
Oh, I see. Yeah, I think it is quite an effective one. I think in terms of potentially, I think that's sort of if you're having real bad issues, I think it might be one that they look into more. But yeah, on the whole, it's in practice. For some reason, yeah, I've not really seen that as much on patients. It's more the sort of levodopas, co-chiral-dopas, and the dopamine antagonists that are mainly used at the moment. I'm sure Parkinson's doctor could maybe give more insight into that, but yeah, it's not as used as much as I've come across.
Yeah, just one more question, if you don't mind, Will. I think Ciaran has a question. Sorry if I pronounced your name wrongly. Regarding the agitation scenario that we discussed earlier, could the dopaminergic themselves be the factor of the agitation?
So, repeat the question, sorry.
I think there was an agitation scenario you were talking about earlier,
Yeah.
whether the dopaminergic medications, I'm guessing is what he means, be a factor of them being agitated.
Yeah, so they can, I mean, there are side effects, and I think agitation can be a side effect of it. So you can get hallucinations from a lot of the medications and even vivid dreams and things like this. So I'm sure the biochemistry of it does indicate that, these are, if on the whole, when you get agitated patients, in all likelihood, it's the driving factor is going to be the thing that they've come in with or presenting with or is their main concern. So if it is something like dementia, that's going to maybe be the driving factor as why they are agitated. And while we can do other things to help that, it's going to be probably that sort of likelihood that's me. So the same with Parkinson's disease, really, and nature of the beast being that the main medications we give can cause some of these agitations or hallucinations. So definitely, yeah. So I think in that scenario, you wouldn't want to obviously stop the medications. So for the short term, you could just sort of maybe give them something if they are risking themselves, or even just try and orientate them, maybe one-to-one them, give them maybe a small amount of lorazepam, and then on the following, when there's a bit more time to sort of assess it fully, you can then look into maybe if they're being over medicated with the medications, or if it's a certain one they're not responding well to change that up. So definitely, I think medications themselves can cause it.
I think that might be all the questions. And Ciaran says, thank you very much, Will.
Okay.
And if there's no more questions, I think we can end the session now. Thank you everyone for
Yeah.
following in. In order to get your certificate, I've attached the feedback form just at the comment box. So if you just press that and fill it up, you'll get a certificate for attendance today. Thank you everyone for joining in. Take care.
Thanks, guys.
Bye.